Okay, let's dive right into this. Welcome to today's Explainer, where we're taking a pretty deep dive into the heart, literally. I mean, if you've ever stared at a bedside monitor and felt your own pulse spike a little bit, you are definitely in the right place. Today, we are mastering the cardiac clinical escalation. We're going to be navigating the complexities of cardiac meds, deciphering those incredibly intimidating glowing lines on the ECG monitor, and talking about how to make split-second clinical decisions. So, let's get started. Here is our game plan for today. We're hitting 4 distinct areas. First, cardiac meds and labs. Second, decoding complex ECG rhythms. Third, why we absolutely must assess before we intervene. And finally, code blue and shock therapies.
All right, Section 1, Cardiac Meds and Labs. This is really about establishing that baseline of care.
Let's jump straight into a clinical scenario. Picture this. You're at the bedside. Your patient is taking the diuretic spironolactone. You glance up at their ECG and you notice tall peaked T waves, a wide QRS complex, and ST depression. Based on those sudden electrical changes, what lab result is your absolute priority to check?
If you guess potassium, you are spot on. Think about the letters SP in spirolactone. That SP literally stands for sparing potassium. Because this medication removes extra fluid, but it holds on to potassium, which can lead to severe hyperkalemia. And when potassium levels soar, it directly impairs the heart's electrical activity. That is exactly why you see those exaggerated tall peaks T waves and that widened QRS on the monitor. It's essentially a chemical problem causing an electrical crisis.
Now, speaking of medications and their unique side effects, consider captopril, or really any medication ending in pril. These are ACE inhibitors. We use them all the time for high blood pressure and heart failure. But they inhibit the breakdown of an inflammatory substance called bradykinin. When bradykinin hangs around, it inflames the airway and causes this persistent, super annoying dry cough. It's totally harmless, but it can literally drive patients crazy. The absolutely crucial takeaway here: educate your patient not to abruptly stop taking it just because of the cough, or they risk severe rebound hypertension.
This is actually a brilliant illustration of how different cardiac lab values act as specific distress signals for entirely different crises. BNP is a hormone released when pressure within the ventricles increases, like when they're stretched out, making it our primary marker for heart failure. Troponin, on the other hand, is a protein released specifically when the heart muscle itself experiences ischemia or injury, like during a heart attack. And D-dimer? Well, that elevates when the body is actively trying to dissolve clots, throwing up a massive red flag for a potential pulmonary embolism. Honestly, knowing which alarm is ringing is half the battle.
Moving right along to Section 2, decoding complex ECG rhythms. We're getting into the heart's electrical wiring now. Heart blocks can be notoriously tricky, but it's really all about recognizing the relationship between the P waves, the atria, and the QRS complexes, the ventricles. In a first-degree block, they communicate, but it's delayed. That PR interval is constant but long, greater than 0.25 seconds. In second-degree type 1 or unke block, the distance progressively lengthens. The P wave gets farther and further away until, bam, the QRS drops completely. In a third-degree block, that is a complete communication breakdown. The atria and ventricles are firing completely independently of one another. Next, let's compare the upper chambers going rogue. Atrial fibrillation versus atrial flutter. In AFib, there's just no organization. The atria are literally just quivering. There are no measurable P waves, and the ventricular response is highly irregular. But atrial flutter? That's where you see those distinctive, beautiful little sawtooth-looking flutter waves. Recognizing the visual difference between a quiver and a sawtooth is vital for knowing your next steps. Okay, time to test your diagnostic skills with a tricky scenario. You're looking at a strip. You count 5 distinct, different P wave shapes and sizes. The heart rate is 80 beats per minute. What rhythm are you looking at? We can rule out AFib immediately, because in AFib, remember, we don't even have true P waves. So what is it?
It is a wandering atrial pacemaker. The key here is the variability. The electrical signal in the atria is actually originating from different locations with every single beat, which alters the physical shape of the P wave. If it were over 100, well, actually, a rate over 100 would make it multifocal atrial tachycardia. But because the rate is a stable 80 beats per minute, it's a wandering pacemaker.
Okay, Section 3, assess before you intervene. This is all about treating the actual human being in front of you. You walk into a room and your patient is in sinus tachycardia at 116 beats per minute. Why? Well, check their temperature. It's 103.6 degrees Fahrenheit.
A simple fever drastically increases the body's metabolic needs, which acts as the exact physiological trigger for the heart rate to speed up. You don't need a dangerous cardiac drug here, you just need to treat the underlying fever.
Now here is another classic bedside trap. Your patient's monitor starts alarming. You look up and see sinus bradycardia with a rate of 52 beats per minute. What is your literal next move? Do you prep atropine? Do you set up pacing?
No, you assess the patient. Not all cases of bradycardia require intervention. You need to actually look at them. Are they confused? Are they clammy and sweating? How's their blood pressure? If all those vital signs are normal, they might just have a low resting heart rate because they're an athlete, or honestly, simply because they're sleeping. Always rule out the baseline before you start pushing medications.
Which brings us to Section 4, Code Blue, and shock therapies. These are the absolute life or death emergencies.
Let's say your patient drops into ventricular tachycardia, or VTach. You check them, they do have a pulse, but their blood pressure has totally tanked to 70/42. They're pale, clammy, and their mental status is rapidly altering. What's your priority? The absolutely crucial point here is that while they have a pulse now, they are highly unstable. They are not perfusing, and they're crashing fast.
For an unstable patient with a pulse, we use synchronized cardioversion. And this brilliantly illustrates the difference between our shock therapies. Synchronized cardioversion relies on timing. It delivers the shock exactly on the R wave. Why? Because if we accidentally shock during the T wave, during repolarization, we risk throwing them into a deadly ventricular fibrillation. Defibrillation, however, is immediate, no timing required. We use that for pulseless, lethal rhythms where we just need to forcefully reset the entire heart.
Speaking of lethal rhythms, what happens if your patient's ventricles are just quivering in VFib? They are totally unresponsive and pulseless. Step 1, call the code blue. Step 2, start high-quality CPR immediately. This is the trick that catches people out all the time. Before you even touch the defibrillator, you have to start CPR to manually get that body perfusing. Only then, while you pump, do you prepare the machine for defibrillation.
And this brings us to a really critical distinction. Why do we shock VFib, but we do not shock asystole, or PEA, pulseless electrical activity? Well, it comes down to the mechanism of electricity. Defibrillation aims to stop chaotic, disorganized electrical activity so the heart's natural pacemaker can regain control. In asystole and PEA, there is no disorganized chaotic activity to reset. Therefore, they are strictly non-shockable rhythms.
Consider one final critical scenario. Your patient is pale and anxious. Their BP is 70/42, and the monitor shows a third-degree heart block, a complete miscommunication between the top and bottom of the heart. How do you intervene here? Do you give a medication like diltiazem? Please, whatever you do, do not give diltiazem. That calcium channel blocker slows conduction and could literally cause cardiac standstill in a block like this. The only answer here is temporary pacing. When the heart's chambers absolutely refuse to communicate and the patient is not perfusing, we have to artificially pace that rhythm externally until we can get them to surgery for a permanent pacemaker. It's the only bridge to survival.
And that really brings us to the core philosophy of everything we've covered in this explainer today. We learn the acronyms, the lab values, and the complex rhythm strips not just for the sake of knowledge. We learn them so that we can step up to the bedside and prevent a patient from deteriorating into cardiac standstill. We learn the theory to save the life.
So I leave you with this final thought. The next time you're on the floor and that bedside alarm starts blaring, will you instinctively rush to treat the glowing lines on the monitor? Or will you stop, take a breath, and assess the patient in front of you first? Thank you so much for joining me on this clinical journey today. Stay curious, stay focused, and keep learning.